Thank you, everybody, for being here, and thank you very much, Simon, for inviting me to come here and to give this talk. So I'm from the Arctic Tromsø, and I'll tell you a little bit about my background and why I'm here. So I was in search of the best Afib researchers in Australia. And back home, I'm a professor in preventive medicine. I also work as a senior consultant part-time in cardiology. My university is called UIT, the Arctic University of Norway. So, and my research interests is epidemiology and prevention of cardiovascular disease with focus on sex differences and risk factors for Afib, myocardial infarction, and heart failure. So first, before I commence, I would like to acknowledge the country, and I respectfully acknowledge that we are standing on the land of the Wurundjeri people who have been custodians of this area for thousands of years. So I found this paper 2.5 years ago, and I wrote to Simon and asked if I could visit them when they were at the IDI Baker due to common research interests. I was then visiting Wollongong Graduate School of Medicine regarding curriculum planning for medical school. And it was about mild cognitive impairment in high-risk patients with chronic atrial fibrillation, a forgotten component of clinical management. And I had just gotten funding for a project with the same topic, but with a very different study design. So I saw this Jocasta Ball, and this Melinda Carrington and Simon Stewart, and I decided I wanted to be their friends. And here I am. So, I'm going to talk about what is Tromsø and what is UIT and what is the Tromsø study. And then I will tell you a little bit about the research that we have been doing the last years on atrial fibrillation epidemiology, and a little bit about our plans. And of course, the last point is about Afib and cognitive function. It's coming up soon. So, where is Tromsø? Tromsø is almost at the North Pole. This is the North Pole, and here is Tromsø. It's the northernmost university in the world. And there are some Russians living so far north, almost no Canadians. I don't know there are so many people here in Greenland, but we are there. And we have a border with Sweden, Finland, and Russia. And Denmark and the rest of Europe is down here. So we have a population of about 2,000. It's an indigenous Sami population there. It's the 8th largest city in Norway. In Norway, there are about 5 million people, and we have more than 140 nationalities represented, even some Australians. Mm-hmm. And at the UIT, there are 12,500 students, 10% from overseas. Staff is about 3,000, and it's a classic multidisciplinary university. This is Tromsø Island, and the municipality also comprises many islands outside. With urban area, it's not so easy to see it's the urban area here, but it is, and the mainland. And it's connected with tunnels and bridges to the other islands and to the mainland. It takes 1 hour and 40 minutes to go by air from our capital, Oslo, so it's very easy. Lots of flights every day, just like in Australia. It's easy to get there. These are things that you can do when you come and visit me. We even have beaches with white sand.
They have an airport.
Of course we have an airport. We don't have any trains there.
Okay.
No, but we have ships. We have ships. It takes from Bergen, our second largest city, to go to Troms. It takes 5 days. So I recommend to go by air. Yeah. 1 hour 40 minutes from the capital.
Maja-Lisa, now I presume the winter photos, they're all just black. You can't see anything.
No, it's not right. From November 20th To January 20th, we don't see the sun at all, but of course there's daylight, but we don't see the sun. It's not completely dark 24/7, no.
And you'll take bookings now for these days?
After my talk, thank you. So this is winter time. It looks like this now. If you saw the first, I will give you the presentation afterwards. But on the first picture that I showed you, there was also this polar light, what do you call it? Northern light, aurora borealis. Yeah, many names. Yes. So the picture of northern light on the first picture was taken Monday evening by some of my colleagues at the campus. Oh, so it's there now. It's from October to March.
Yes.
So and this is a city center. Yeah. And so a brief outline about the Tromsø study. It was founded back in '74 due to the CVD epidemic that hit your country and our country and very much North Norway. We were on the top of the world together with Finland and North America. So, and the aim of this study was to study causes of cardiovascular disease, risk factor surveillance, and to prevent the disease. And it's not only cardiovascular disease anymore, it's a lot of other diseases also that are part of the Tromsø study. So this is our research lab. It's a current population of 72,000. Back in 1974 it was less than 40,000 inhabitants, so it has increased and it's still increasing. People, just like in Australia, they are moving from the countryside into the urban area. And we have more than 40,000 adults in the data, and a little more than 1,100 teenagers. And we know that the Tromsø study has contributed to improved public health, to excellence in medical research, for instance, collaboration with Australia, and more than 100 PhD theses have been completed. Mine was one of them 20 years ago, and 65 are in the pipeline, and more than 30 master's degrees. And we know that it has improved treatment of patients as 2 or 3 PhD candidates are clinicians from the university hospital, other hospitals in North Norway region, or GPs. And it's been a health registry for 40 years. We are now performing the 7th wave of the Tromsø study screening. So we invite the participants that have been participating before, and always new cohorts. The largest one was in 1994-95, then about 25 participants came and were invited, and 72% participation rate. And for this screening that is going on now, we invite 22,000 and hope to have a 70% participation rate. So, and we do questionnaires and biological specimens and a lot of measurements and some clinical examinations, including ECG, electrocardiogram, and heart ultrasound and cognitive function. And this is just to show our heart disease. It's my PhD that was 20 years ago, and one of my closest colleagues, Henrik Schimmer's PhD, that was on echo 15 years ago. And we are collaborating very much on different heart diseases, but at the moment I'm doing very much on Afib. And I have 2 PhD students and 1 postdoc, and then some master students from medical school who are doing different studies on Afib epidemiology. And we follow up the baseline data with the linkage to the mortality register on total and cause-specific mortality, on the cancer register. I don't work on cancer now, but I've done a little bit before. And then we have our own Tromsø study disease registries. We link our participation database to the discharge register of the university hospital, and then we adjudicate all the cases on myocardial infarction, atrial fibrillation, and all the strokes. Yeah, and we also do other diseases. And I think I started in 10 years ago because I was responsible and still am for this disease registry. I was looking through all these files and started to think, as I am a cardiologist also, there are so many of these myocardial infarction patients that also have atrial fibrillation, so why? Maybe we should start to collect they also. So we went back to 1986, the third Tromsø study, and have looked and collected all the endpoints since then. We have now about 1,000 participants that have a diagnosis of Afib, and they have to have an ECG that documents their Afib. What we don't have all the patients that only see their general practitioner. But nowadays, most of the patients with Afib also see a specialist at the hospital. So we think we are, well, that we have almost all the participants. What we are doing now in the 7th Tromsø study screening about a random sample of the participants who come to the screening. They also wear recorder for 1 week, both to record heart rhythm and activity. So then we will get a better estimate of the true prevalence in the population, which we don't really have now because it's only the hospital data. So we started to collect all this data, and we didn't really know what we should do with them, but we collected them and tried to think about what can we do. And we had a medical student who did a master's in 2003, and she could then show that there had been a doubling of the cases, doubling of the incidence of Afib in our population during the last 10 years. And that could be, is that a new epidemic? Is it due to more attention to the disease? Is it better diagnostics? Is it because more people survive heart disease, or we have more old people in the population? Or is it a change of risk factors in the population? And I was particularly interested in the risk factors. And so, almost at the same time that she did this, a couple of years later, I think it was in 2008, we got an invitation from a group in Iceland, one of our neighbor countries, who had done GWAS on the whole population in Iceland, and was looking into Afib genetics. And they were looking, and they had found some gene locus that was significantly correlated with Afib, but they needed to kind of confirm this in similar populations. So they were looking for Norwegian populations that they could use in the case control study. And the only one in Norway who had this data, they were us, and because we had also collected DNA from 1994. So we could give them 700 cases and 700 controls, and then we were very happy. That was kind of the start of our research, because it was published in Nature Genetics, which is one of the top journals. I didn't know that then, because I didn't really read those journals at that time, but I've started to do that after this publication. So we were co-authors there, and that was fantastic. So then the year after, one of my colleagues, he was actually my supervisor at the medical school, Dag Telle, he said, we should write a book on Afib, because this is, he's also an epidemiologist and a physician. Because now we know everything about it, I think we should write this book, and yeah, and we did. And in that book, which is called Chaotic Hearts, Afib, a Modern Epidemic, it was like a success. And it was sold out in many reprints, yes, and I didn't earn very much money, but became a little bit famous on this, in this area, and I got a lot of money. I got for all this, not as research excellence as you have, but for all the PhD proposals, it was not difficult to get money. So that was fun. It was, so I decided I will focus more on Afib than on myocardial infarction that had been my previous area of research. So this was our first PhD student, Audun Nyhus. Her PhD is now being evaluated by a committee, so I hope it will be approved. We will get the answer in November, and she has been looking at risk factors, occurrence, and gender differences, and based on our data. So her first paper that was published in Preventive Cardiology was about all the classical risk factors like hypertension, diabetes, previous cardiac disease, BMI, physical activity, alcohol. We looked at everything, and we didn't find any surprises then, but we also found that if you had reported that you had palpitations 11 years before the outcome, you had a much higher risk. So then we could show that the feeling of irregular heart rhythm, it's not only psychiatry, which I thought before, but it's really a risk factor. So that was her first paper, and then she wrote 2 papers on different inflammatory biomarkers that was published in Gender Medicine in 2012 and in the Europace last year. So yes, and I looked up yesterday, and the papers like this are not cited enormously, but they have both been included in review articles after this. So that is, I think that's good. Yeah. Yeah, she for both papers she showed one of the things that she showed that many papers have not shown before. She showed sex differences in these biomarkers, and it was like in the general population, which is not always the matter in the papers like this. Often it's kind of more hospital populations. So we had the general population, which was new, and we had both sexes, and we had a long follow-up, and like more than 6,000 participants. And then our last paper was published in Heart this spring, and it is about it's called diastolic dysfunction, which is something that you measure with echocardiography. This is the heart, and this is the left ventricle of the heart, and this is the left atrium of the heart. And the diastolic dysfunction, it has to do with the size of the left atrium. If you have a larger left atrium, you have a higher risk of atrial fibrillation, and higher larger left atrium is caused by hypertension, overweight, diabetes. Those are the most important risk factors. So we were able to show that in the general population that has not been published before, also later increasing size of left atrium is a risk factor for later atrial fibrillation. So I'll just show one figure from this paper. And this is the largest left atrium size. So it's quite a difference according to size. And this article is also published with a video abstract. So if you're interested in the left atrium, in 4 minutes, me and my PhD student, we can tell you everything about it in 4 minutes. It's in the video abstract, which is in YouTube. It's linked to the article. So the Heart Journal invited us to make this abstract, and we did. And we got professional help in editing it, and yeah, it's quite good. I will just show this. This is just a small student project that we did this spring with a second-year medical student. She was interested to learn about atrial fibrillation. So my boss at the hospital, who is the guy who does our Afib ablation. Afib ablation, atrial fibrillation ablation, that is, you go into the left atrium of the heart, and then you burn or freeze the foci that cause the atrial fibrillation, the dysrhythmia. So it's a kind of surgical treatment of this disease, which is now increasing very much. So what she did, she looked through 140 patients that had been treated with ablation in our hospital last year, and what she found, 82% of these patients were men and 18% were women, and that doesn't mirror the distribution of AF in the general population. And so we wrote this in the report, and my boss, he was not furious, but almost. I am not discriminating the women, is that it's the GPs that don't send the women to us. So I take everybody. Yeah. I don't discriminate by sex, but I think it's interesting.
Yeah.
So anyway, and we also looked at, you see they are overweight, BMI 28.5 in men, 26.9 in women. 40% of them have hypertension. 30% of the women had previous heart disease. 9% of the men. The men are the runners, you know.
Yeah.
Yes,
that's right.
That's the guys.
Yeah.
Like Gary, he will be.
Yeah. He'll be having an ablation soon.
And also, like 40% have this enlarged left atrium. These are the data that we looked at, and we
probably because they're BMI.
Yeah, I think so. So, and hypertension and diabetes. That's right. And what my boss was interested in, he said, I know, he said, that about 30% have a redo. They come back. So, can you look into this? My boss is fantastic boss, and he's very good in doing ablation, and he knows everything about this, but he doesn't do research. No, he doesn't even have a PhD. So that's why he wants me to
you.
Yeah. And this is good. So the predictors for recurrent AF half a year after, we looked through all the files of the patients half a year after and counted how many you still have Afib or have got it back. And that was BMI and diabetes. And since you are interested in looking at this,
Yes.
I think I wanted to show this to you.
Yeah, lovely.
And this is this will be the third and last paper in my PhD students' PhD. So this is on atrial fibrillation as predictor of cognitive function in stroke-free subjects. And for this paper, which we will start working on this fall, I have been. That's why I'm here. I wanted to have Dr. and Simon with and they have said yes. So they only know the title, but they said yes. you know the data.
Yes.
They're good.
Yeah.
They're good. So this is the end. So thank you very much.
Thank you.